Okay, good afternoon. Thanks to the organizers for offering us this opportunity to talk about food allergy. I'm sure it's a common issue that many of you are dealing with for your patients. And even though we're late in the afternoon, I'm hoping that we'll be able to wake you up and talk about some important clinical pearls, I think, when it comes to evaluating children with food allergies. So I'm Hemant Sharma. I'm one of the allergist immunologists at Children's National. My colleague, Dr. Jamie Wolf from Gastroenterology and Nutrition, will be talking today. And really, we're highlighting what is a comprehensive food allergy program at Children's National. And we certainly hope that you will continue to send more patients our way. Today, in terms of learning objectives, we wanted to begin the discussion by talking about the various types of food allergies. And the easiest way to think about this is the underlying immunologic mechanism. Then after going over the types of food allergy, we'll move to a discussion about how to recognize and diagnose various types of food allergy. And then a little bit about the natural history and treatment of food allergy. And then finally, we'll discuss when to refer a patient with food allergy to a specialist. I'll be focusing mostly on IgE-mediated food allergy, as well as a few of the gastrointestinal forms of food allergy. And then Dr. Wolf will discuss more specifically eosinophilic esophagitis, which is something that I'm sure many of you are seeing more and more of. So first, in terms of the most basic definition, what is a food allergy? Well, there's two components, I think, that are important to consider when conceptualizing food allergy. The first is that it's an immunologic response, and so it's mediated by the immune system. If something in terms of a food reaction is not mediated by the immune system, by definition, it's not a food allergy. It's something else. And then the second key part of the definition is that this is an adverse immunologic response to a food protein. And that's important because in the food that we eat, there are many different components. There's carbohydrate, there's fat, and then there's protein. And it turns out in a food allergy, the immune system is reacting specifically to that food protein. So now that we've discussed the definition of a food allergy, what conditions are not food allergies? Well, probably the most commonly confused condition with food allergy is lactose intolerance, which is in fact a reaction due to the fact that the lactase enzyme is deficient. And this is due to carbohydrate within the food, lactose. It's not due to protein within the food. And in fact, it's not mediated by the immune system at all. And so based on our definition, it doesn't qualify as a food allergy. Other things which can look like food allergy but not necessarily be food allergy, responses to pharmacologically active components. So for example, scombroid poisoning, usually stale brown fish, has histaminic components inside of the fish itself that upon ingestion create symptoms that look a lot like a food allergic reaction, but it's not mediated by the immune system and it's not due to a food protein. In terms of the prevalence of food allergy, as many of you probably would guess, the numbers are quite high. And currently our best estimate is that 3 million children in the U.S. are affected by food allergy. And just to put that into perspective, asthma, which is in fact the most common chronic illness of childhood, affects 6 to 7, maybe 9 million children. Food allergy isn't very far behind. And so percentage-wise, young children have a prevalence of 5 to 8%, adolescents and adults a little bit lower, 3 to 4%. And then when you extrapolate those nationwide numbers to our region, that means that there's an estimated 50,000 children with food allergy just in the Washington, D.C. metropolitan area. So incredibly prevalent. What's perhaps even more worrisome is the fact that these numbers are increasing. And every day we're seeing more and more children who are being diagnosed with food allergy. In the literature, perhaps the one food allergy that's been looked at the most in terms of prevalence is peanut allergy. And Scott Sisher and their group up in Mount Sinai in New York have looked between 1997 and 2008 at the rates of food allergy and have shown that peanut allergy in particular has tripled just in about a decade, which is astounding when you think about it, that the rate of peanut allergy has gone up 3 times in the span of 10 years. The prevalence of food allergy overall has increased about 18% in that similar time frame. So a very prevalent problem, and in fact one that's increasing in prevalence every single day. And one of the questions that we get asked every day by parents and other colleagues is, why is this happening? Why is the prevalence going up? And I've listed here various theories that are being studied right now. We don't really know the reason why, and there's not great evidence supporting any one of these theories over the others. But things that have been suggested include the hygiene hypothesis, that we're simply too clean of a society now, that infants early in childhood aren't being exposed to pathogens and their immune system gets distracted by food allergy. Changes in our diet, changes in the way food is processed, that's been proposed. And perhaps the most interesting recent hypothesis is that the fact that we advise delayed introduction of foods during infancy may in fact be predisposing towards an increase in the prevalence of food allergy. And for example, we think that the longer a food is delayed orally, that gives the skin a chance to be sensitized to that food cutaneously. And we think oral routes of introduction are tolerizing, whereas cutaneous routes might be sensitizing. So again, not compelling evidence for any one of these particular theories, but there's a lot of research ongoing right now to try to get to the bottom of why the prevalence is going up. In terms of the types of food allergy, I mentioned before that it's the easiest way to conceptualize food allergy is based on the underlying immunologic mechanism. So when you look at food allergy from an immunology point of view, there's three different boxes that it can fall into. One is that it's IgE-mediated. So IgE is the allergic antibody that's produced in children after they've been sensitized, and upon re-exposure to that food is responsible for the activation of mast cells, basophils, other allergic cells, which release their allergic mediators and cause the symptoms. These symptoms are acute in onset. They happen within minutes after exposure to the food and can produce conditions such as anaphylaxis, oral allergy syndrome, exercise-induced anaphylaxis, which is food-associated. So that's what I'll be discussing for the majority of our time today. On the other end of the spectrum, you have cell-mediated food allergy, which, when you look at it on a pathophysiologic level, is mediated by T cells. And by the nature of T cell inflammation, it takes time. This is not something that will happen immediately after the food is ingested. This takes several weeks usually for the inflammation to develop. So it's delayed in onset, and it produces more chronic symptoms rather than acute. And I'll discuss later on enterocolitis and proctitis as the prototypical cell-mediated food allergies. And then you have this category in the middle, which has features both of IgE and non-IgE mediated food allergy. And eczema, in fact, can be considered in that middle category because about a third of children with severe eczema have food allergy that's driving their eczema severity. Not every child with eczema will have food allergy as a trigger, and even those who have food allergy as a trigger, they have a multitude of other factors which exacerbate their eczema. So it's not as if we'll find food allergies in a child with eczema and all of a sudden they'll be cured. There are other factors at play. And then, as I mentioned, Dr. Wolf will talk more about eosinophilic gastrointestinal disorders. So in terms of IgE-mediated food allergy, we're all familiar with the signs and symptoms. So in the skin and on the mucous membranes, we can see hives, swelling, itching and swelling of the tongue, the lips, the throat. What you can't see in this picture are the symptoms that might be going on internally. So in the GI tract, nausea, abdominal pain, vomiting, diarrhea. And the respiratory symptom, both upper respiratory, so rhinorrhea, sneezing, as well as lower respiratory symptoms such as wheezing and shortness of breath. And then finally, cardiovascular symptoms such as low blood pressure and syncope. Anaphylaxis is something that oftentimes is difficult for patients to get a sense of what we're really talking about. And when we talk about food-induced anaphylaxis, what I find is the easiest way to convey this to parents is that it's a systemic reaction that involves two or more organ systems. So meaning that it's a progressive reaction. It's not localized simply to a hive on the cheek, but it's progressing. The hives elsewhere, vomiting, potentially problems breathing. Anaphylaxis is acute in onset, and it can actually vary in severity from mild to fatal. So food allergy can kill children. The course of anaphylaxis allows us to distinguish a few subtypes, and most food allergic anaphylactic reactions are going to be uniphasic, meaning that there are symptoms that develop shortly after ingestion of the food. Those symptoms resolve and they don't recur. But about a third of reactions can be biphasic, meaning that you'll have that initial wave of symptoms, And then within 3 to 4 hours later, sometimes a little bit longer, you have a second wave of symptoms that arises. And protracted anaphylaxis, in fact, is actually very rare. And so it would be very unusual for a patient to have signs or symptoms of anaphylaxis that simply persist for several hours or even days on end. There's usually another explanation if that does happen. So we talked about the definition of anaphylaxis, and we've talked about the prevalence of food allergy overall. But what about the prevalence of food-induced anaphylaxis? Well, it's actually also very common. It accounts for about 125,000 ER visits per year, and is in fact the most common cause of visits for pediatric anaphylaxis in our emergency departments across the U.S. What's perhaps even more worrisome than simply the numbers of children that visit the emergency department for anaphylaxis are the fact that it can be fatal. So each year there's about 150 to 200 deaths from food allergy across the U.S. And when we look at the registry of fatalities from food allergy, there's 4 factors that can be extracted as the main risk factors that will predict which child might be at highest risk for a fatal food allergic reaction. First, adolescents and young adults. So obviously, risk-taking plays a role here. And I've actually done some research that suggests that there's some inherent factors to the lifestyle of adolescents and young adults that put them at especially high risk for food allergic fatalities. Asthma, so children with asthma are often misrecognized as having an asthma exacerbation instead of anaphylaxis, and that can contribute to delayed treatment. Peanut and tree nut allergies characteristically are the most dangerous food allergies, meaning that when you look at the registry of fatalities, the majority of them are to nuts. And then finally, delayed administration of epinephrine. So almost universally, every single fatality that occurs is because epinephrine was either delayed or it wasn't given at all. So how do we diagnose IgE-mediated food allergy? And I find that from my colleagues in general pediatrics and family medicine, this is perhaps the most difficult part for you. And I want to emphasize the importance of the history, because even when patients are referred to us for further evaluation of food allergy, we always go back to the history. And it's in fact the history that's the critical part of the diagnosis. So what are we evaluating in the history? Well, we want to know what food caused the reaction, or what food do we think caused the reaction? How much of that food was ingested? What was the time course? So how long after ingestion did the symptoms develop? We said for IgE-mediated food allergy, it should be pretty quickly, within minutes. And then what was the reaction consistency? And so if a child had a reaction to peanut, but they've been able to eat peanut for years before that, and even since this reaction, they've been able to tolerate peanut without any symptoms, they don't have a peanut allergy. And so the history there tells you that whatever that reaction was that they supposedly had to peanut, it was something else that triggered it. And so the consistency of reactions with repeated ingestion of the food is perhaps one of the most important parts of the history. Diagnostic testing is just supportive. And so there's a lot of testing that we'll discuss that we can do after patients are referred to us, but all of them are interpreted in light of the clinical history. So what testing can we do after a patient gets seen by an allergist? Well, skin prick testing is where we put extract on the surface of the skin and assess the local IgE response in the epidermis. It's a quick test, so we put it on and then we assess about 15 minutes later. So by the time patients walk out of the office, there's some sort of a result there. The negative predictive value of skin prick testing for food allergy is actually quite good. It's greater than 90%. And so if your pretest probability based on the history was quite low, you heard about the reaction, but it really didn't seem to you like this was a food allergy, then sending a patient to us to get skin prick testing done might actually be a good idea, because if that skin prick test is negative, we can almost 100% say that they don't have a food allergy. The specificity of skin prick testing is not 100%. So sometimes you will end up with false positives, and that's why I go back again to the history being the most important part of the diagnosis. Atopy patch testing is a different kind of skin testing where the allergens are placed usually on the back in chambers and left on there for 48 hours and then assessed immediately after removal and then 24 hours later. And this is looking not for the IgE response in the skin, but looking for the T cell response, the delayed response to the food. And there might be some utility for the evaluation of non-IgE-mediated food allergy, but this remains somewhat controversial. Serum immunoassays, so we used to call these RASTs, but that term has fallen out of favor because the methodology is in fact not radioactive. It's a chemilucent assay. And what what serum immunoassays do is they assess food-specific IgE levels. And so in the patient's serum, what is the quantity of IgE that they have to each of these specific foods that you're testing? In general, the higher the level is, and it can range anywhere from 0.1 up to 100, the higher the level is, the higher likelihood that they're going to have a reaction, but there's no correlation with the severity of the reaction. So a child may have a milk-specific IgE greater than 100, but they could have an accidental exposure to milk and just have very mild symptoms, whereas a child with a milk-specific IgE of 2 could have anaphylaxis. And so there isn't, unfortunately, a correlation with the height of the IgE level and the reaction severity. What we use serum immunoassays mostly for is looking at trends over time. And so we tend to repeat immunoassays annually once a food allergy has been diagnosed, and then we look at what that trend is. If the numbers are coming down, that might indicate that the child's immune system is outgrowing the food allergy. If the numbers are stable or going up, the opposite might be true. Food challenges are usually done for one of two reasons, and these are done in an observed medical setting where we have emergency medication on hand in case a reaction should occur. It can be performed to confirm the diagnosis if the history and other testing wasn't clear, or it can be used to assess the resolution of the allergy. And that's mostly the reason that we do oral food challenges, is if we, based on our testing done over time, the trend suggests that the child has outgrown the allergy, we would offer an oral food challenge in our clinic and actually see, in fact, if they've clinically outgrown the allergy. And then elimination diets can also be performed mostly for the chronic gastrointestinal forms of food allergy, where you remove the food and then over several weeks you assess what happens to their symptoms. So what are some potential pitfalls with diagnostic testing? It's tricky. And so one of the key pitfalls is that positive test results only indicate sensitization. They don't necessarily indicate clinical allergy. So again, just because the skin test was positive or just because the IgE was positive, that does not mean that a child has a food allergy. It only indicates that they have IgE in their system. It doesn't indicate that upon exposure to that food that anything is going to happen. So we recommend against screening with indiscriminate panels. And so a lot of labs will offer the food allergy panel, and it includes 6, 7, sometimes 8 foods. It doesn't really make sense sending off those panels because your testing should really be guided by the history. And so if a food is being tolerated in a diet, it doesn't need to be tested, because all that will happen inevitably is that the number will come back positive, and then you're left with a food that they have eaten for years without any reaction, but a positive result that's worrying the parent. Another potential pitfall is that manufacturers don't always do the same method of serum IgE testing. So there's 3 methods that can be used, and ImmunoCAP is the one that's been used for all of the food allergy research to date. So when we're able to look at levels, specific IgE levels, and say that when the number drops below 2 for milk, they have a 50% chance of passing a food challenge, that's an ImmunoCAP level of 2. But the other 2 methodologies, TurboRast and Immulite, it's not going to be 2. In fact, no one knows what it is. But studies have been done comparing the 3 methodologies, and they come back differently. And so it's very important that if the testing is done by different manufacturers over time, we need to take extreme care in interpreting those results, because you can't necessarily establish trends if they were done using different methodology. Just to let you know, ImmunoCAP testing is what Quest uses, but LabCorp does not use ImmunoCAP. And then finally, negative test results don't rule out a food allergy. And so, for example, they've done studies with peanut allergy where up to 20% of kids will react during a food challenge, but they'll have a negative specific IgE. So their IgE is less than 0.35, but yet they're reacted on food challenge. So a convincing history shouldn't be ignored. The prevalence of food allergy is listed here for a variety of food allergens. Milk, egg, and peanut are the most common food allergies among children, and then shellfish, peanut, and tree nut are the most common among adults. And you might be wondering, well, why is it different? Why are there some food allergies common among kids and others among adults? Well, the reason is because of the likelihood of resolution. This is, in fact, allergen dependent. So for milk, egg, soy, and wheat allergy, children are more likely to outgrow those allergies on their own as compared to peanut, tree nut, fish, and shellfish allergies. Even though milk, egg, soy, and wheat are likely to be outgrown, recent research is showing that they might be taking longer to be outgrown than we used to believe. So only less than half of kids with milk allergy, for example, will outgrow it by the time they're school age. And we used to think that if you didn't outgrow it by the time you're school age, that you were never going to outgrow it. We now know that that's not true. Peanut allergy is usually lifelong. Only about 20% of children will outgrow it. Tree nut is even more persistent. Only about 10% will outgrow it. This is a study done at Hopkins a few years back, just looking again at this idea that milk allergy appears to be more persistent than we used to think. So at 6 years of age, for example, only about 10% of children at best have outgrown their milk allergy, but by age 18, upwards of 80% have. So definitely there's still a chance to outgrow it even into the teenage years. Treatment is really centered around avoidance of the food allergen and carrying emergency medication. So we advise patients to always have antihistamines and epinephrine on hand in case of an allergic reaction. The future therapies for food allergy that are being investigated right now are actually quite exciting, and there's been a lot of attention recently on oral immunotherapy for milk, egg, and peanut. And while the results initially look quite good, I have to emphasize that these are experimental therapies, and so there's nowhere where this is being done outside of a clinical research protocol. But I do think that we'll get to a day where we'll be able to treat food allergy by desensitizing the child's immune system through the gradual introduction of food. This is an example of a food allergy action plan, and I just wanted to refer folks to the Food Allergy and Anaphylaxis Network. That's where this action plan is from. Their website is foodallergy.org, and you can access copies of this action plan. It's imperative that every child who has a diagnosis of a food allergy have one of these on file with their school and or their child care center, because otherwise there's not going to be anything in writing for the providers to know what to do when that child has anaphylaxis. The treatment of anaphylaxis is really epinephrine, and as I mentioned, a delay in the treatment with epinephrine can be associated with fatality. Epinephrine can be repeated after 10 to 15 minutes if symptoms are persistent. And we usually recommend that if epinephrine has been given, that the patient come to our emergency department for observation because of the risk of that biphasic reaction that we talked about. A couple of common myths when it comes to food allergy. So it doesn't always present with skin symptoms. Anaphylaxis in about 20% of cases doesn't involve hives or swelling. And in fact, 80% of fatal food allergic reactions don't involve any skin symptoms. The other myth that I think is important to keep in mind is that the past reactions don't necessarily predict what the future reactions are going to be like. So simply because a child had a very mild reaction to peanut the last time they accidentally got into some, that doesn't mean that their next reaction is going to be just as mild. It's completely unpredictable. So now to move on to that other category of T-cell mediated food allergy. And first starting with something called FPIES, or food protein-induced enterocolitis. Chronic exposure in this patient population can lead to GI symptoms. Re-exposure after restriction classically had this presentation 2 hours after ingestion of causing emesis, diarrhea, hypotension. The most common culprit foods for FPIES are milk, soy, rice, and oat. And the diagnosis is clinical. So because it's T-cell mediated, IgE testing is going to be of no utility here. The management is basically to avoid the culprit food in the child's diet and then to re-challenge usually about 3 to 4 years when we think most of the cases of FPIES are outgrown. And then the prognosis is quite good, as I mentioned. It usually is outgrown by early childhood. The last topic that I'll discuss before turning it over to Dr. Wolf is food protein proctocolitis or proctitis. And this is commonly referred to as milk protein allergy, but I hope what I've convinced you of is that that's a really generic term that doesn't have much specificity. Bloody stool in infancy is usually how it presents. The culprit foods are cow's milk and soy, usually in breastfed infants. Again, a clinical diagnosis, no role for IgE testing because it's T-cell mediated. And then the management is simply avoidance of what we think is the culprit food. If the mom is breastfeeding, we usually recommend avoidance of milk and or soy. If she's not breastfeeding, a hypoallergenic formula can be used. 80 to 90% of proctitis will respond just to a hydrolyzed formula, like Alimentum or Nutramigen. So you don't necessarily have to go to the elemental formulas, which are more expensive, and those are Elecare and Neocate. And then again, this has a very good prognosis, and so we usually recommend introduction of the food at home at 12 months or later. So at this point, I'll turn over to Dr. Wolf, who's going to talk more about eosinophilic esophagitis, and then we'll take some questions afterward.
Hi, I'm Jamie Wolf from Gastroenterology, and I wanted to start by talking about eosinophilic esophagitis, which is really by far the most common manifestation of GI allergic disease. So, most simply put, EE is characterized by eosinophilic inflammation of the esophagus. More specifically, it's a non-IgE-mediated response to a food trigger in a genetically susceptible host. And fortunately, in 2007, an expert panel came up with some formal diagnostic criteria, which has really helped kind of streamline the diagnosis of these children and adults. And these diagnostic criteria are, one, characteristic histologic findings, primarily at least 15 eosinophils per high-powered field in the esophagus, as well as characteristic symptoms that don't respond to high-dose acid suppression or are in a patient that has a normal pH probe monitoring. And EE was first described back in the 70s in 2 case reports. These were 2 adults, both of whom had symptoms including dysphagia, epigastric pain, some esophageal spasms on motility studies, and both had increased eosinophils in the esophagus or the small bowel. And so from then on, for the next 2 decades, a lot of focus was on reflux as a potential etiology to these findings. But it wasn't until the early 1990s that EE became recognized or started to become recognized as a distinct entity. And this started with a retrospective review published in '93 by Atwood, in which they looked at 12 patients who had increased esophageal eosinophils. The vast majority of them had normal pH probe monitoring. About half of them were atopic in other ways, and the majority of them had dysphagia or frequent food impaction. And they compared these patients to 90 patients who had proven GERD on pH monitoring. About half of these patients had eosinophilia, but with a mean of only about 3 eosinophils per high-powered field, with a range up to about 19. The 12 patients had a mean of 56 eosinophils with a range up to 100. So clearly there was a difference in these 2 populations. And this study really spurred people to investigate EE as a distinct pathophysiologic process. So EE is on the rise. The incidence is estimated at about a little over 1 in 10,000, with a prevalence of about 4 in 10,000 in children under age 19. It affects children and adults. Typically young men in a 3-to-1 ratio over women. And these patients typically have a high rate of atopy. 2/3 of them have a history of asthma, rhinitis, other allergic disease, and up to 75% have a personal or family history of atopy. So these kids typically present with abdominal pain, vomiting, or dysphagia, but really the symptoms are very age-dependent. So the infants and toddlers tend to present with feeding difficulties, the school-age children with abdominal pain, vomiting, and the older kids and adults with dysphagia and food impaction. And you can see the differential diagnosis of esophageal eosinophilia is quite large. The most common distinction that has to be made is between food allergy, so EE, or gastroesophageal reflux. So some questions you might want to ask yourselves or your patients is there any other atopy present? Is the onset of symptoms with the introduction of solid foods, which is typically, aged 6 to 24 months is typically when we start to see the manifestations of EE. Any particular food avoidances in your kids? Do the children have any difficulties feeding, including slow eating, excessive chewing, having to drink water to wash their food down? And of course, has there been any growth failure? So unfortunately, there are no physical exam findings that are diagnostic for EE. You may see some other characteristic signs of allergy, such as allergic shiners, reactive airway disease. And likewise, there are no diagnostic tests that we could obtain in the laboratory. I just want to mention that mild peripheral eosinophilia is seen in less than 50% of patients with EE. So it can be a red flag for atopic or allergic disease, but it's really not something to rely on. Allergy testing, as Dr. Sharma mentioned, has no direct correlation with non-IgE-mediated disease. It usually is more helpful in directing therapy, which I'll talk about later. And some research is being done into the immunologic mechanisms underlying EE, and hopefully in the future we'll have some non-invasive ways to evaluate or screen for EE, including measuring cytokine levels. Primarily IL-5 and IL-13 have been the big ones in the literature. So really, biopsies and histology are where the diagnosis lies. You can see on the left panel, that's a normal esophagus, nice pink, smooth mucosa. The other two panels show some characteristic findings on endoscopy, and that includes longitudinal furrowing as well as trachealization of the esophagus and exudates. But I will mention that up to 30% who have histologic findings consistent with EE have grossly visually normal mucosa. So really, it's the biopsies that are key. And I don't know how well you can appreciate this, but on the left there is a picture of an esophageal biopsy with numerous eosinophils. And again, the formal diagnostic criteria designate greater than 15 EOs per high-powered field. And with GERD, you typically see less than 7. So that's important for us to remember. And on the right, you'll see some advanced changes from ongoing EE, and this is demonstrated by the arrows, which shows some indentations secondary to concentric ringing in the esophagus. So really, the management goals are primarily threefold. The first is symptom control. The second is histologic normalization, and the third is avoidance of complications such as stricturing or growth failure. Diet is really the mainstay of therapy. There are generally 3 ways to approach this. One is directed elimination, for example, using skin prick testing or immunocap results to help identify potential allergens. Empiric 6-food elimination, so elimination of the top most common allergens is also employed. And then, of course, an elemental diet, especially in the kids who you suspect have more severe disease. Pharmacologic therapy is also used typically in the more moderately to severely affected children. So, for example, those with significant growth failure or significant dysphagia preventing them from swallowing food or obtaining the proper nutrition. This is generally given in one of 2 ways. One is swallowed steroids, so swallowed Flovent or swallowed budesonide mixed in a little liquid, or systemic steroids, typically for the more severely affected kids. So before I end, I just want to mention there are a few challenges that we face in diagnosing and managing EE, and I think the primary of which is that the natural history of this is not fully understood. For example, there's such variability in symptoms. Do these different symptoms represent different phenotypes, and would these phenotypes respond preferentially to different types of treatment? These are things that are being looked at in the various studies going on. Furthermore, is adult EE a continuation of pediatric EE, and should they be treated in the same way? This is something that's still not clear to anyone. And again, distinguishing EE from GERD continues to be a challenge. So we do the best we can based on the information that we have, but hopefully we'll get more clarity on that in the future. And it would be nice to have some non-invasive methods for assessing the disease. These kids typically need to undergo repeat endoscopies, which, as you know, are invasive and costly. So hopefully the research, especially into the immunology underlying EE, will help provide some non-invasive methods for diagnosis. And then finally, treatments. There's controversy as to who should be treated and how they should be treated. Is the goal symptomatic or histologic improvement. What do you do with the asymptomatic patients? I know a lot of adult docs typically, they don't re-endoscope. If the adult gets better, they just follow them clinically. We tend to re-endoscope and get histologic biopsies in the children. And there are, a multitude of quality of life issues when it comes to treating these kids and deciding how and who to treat. And that's, both diet, medication, as well as the need for repeat endoscopies, and continual medical follow-up. So in summary, the diagnostic guidelines for EE are characteristic clinical symptoms, along with histologic findings, primarily at least 15 eosinophils per high-powered field. Failure to respond to high-dose acid suppression, namely 2 mg per kg per day of a PPI, or normal pH probe monitoring. Those were also required. EE is a chronic condition with persistent or relapsing symptoms, and I hope you would suspect it in any child who has abdominal pain, vomiting, dysphagia, or food impaction. And again, the mainstay of therapy is diet, plus or minus pharmacologic therapy. So I'll hand it back to Dr. Sharma. I'd be happy to take any questions afterwards.
So this is our last slide, and really just wanted to round out by giving you some guidelines of when it might be helpful to refer a patient to the food allergy program at Children's National. We're happy to see any patient, but obviously given the vast numbers of children with food allergy, every patient can't necessarily be seen by a specialist. But for IgE-mediated food allergy, if a child has severe or multiple food allergies, then really they should see an allergist immunologist. If the clinical history wasn't clear and we're not certain what exactly caused the episode of anaphylaxis, then also it would be appropriate to refer. If there's any need for further testing or for interpretation of testing, then that would be a case in which we can be helpful. And then finally, if there was a history of anaphylaxis, no matter whether it's known to an allergen or unknown, they should see an allergist. Oral food challenges are something that we can offer at our clinic in order to assess either initial diagnosis or resolution. And then finally, severe atopic dermatitis. And so emphasize here severe. So if it's a child who had mild atopic dermatitis, it's unlikely that we're going to be able to identify a food allergen that's contributing. However, if it's a child with severe atopic dermatitis, it might be helpful for us to do an evaluation for a food allergen component. And then lastly, gastrointestinal or non-IgE-mediated food allergy. If a child has failure to thrive, then certainly it would be helpful to refer them to see one of our gastroenterologists at Children's National. Severe or persistent symptoms, particularly those that fail to respond to acid suppression therapy. And then if there's any systemic findings, such as anemia or hyperproteinemia, then it certainly would be helpful to try to get to the bottom of what could be causing that gastrointestinal food allergy. So with that, we'll close, and Dr. Wolf and I will be happy to take any questions that you might have.
Who gets the EpiPen? Everybody with food allergy, vague symptoms?
Yeah, so if a child has a diagnosed IgE-mediated food allergy, they should be prescribed an EpiPen. If there's any lack of clarity with regard to the diagnosis, then they should be referred to a specialist in order to confirm that diagnosis.
That diagnosis, is that skin testing? Is that a rash? What are you talking about?
Clinical history guided. And so if the clinical history is consistent, despite the fact that they might have negative skin prick testing or IgE testing, then we still would give them an EpiPen and tell them to avoid the food. Yeah.
My question is regarding the interpretation of the immunocap assays. So I had a patient, a 3-year-old, with positive titers for walnut and sesame, and mom has never given either or, and very low titers for peanuts. So what do you do? Like, how do you advise patients in those situations?
Yeah, so that might actually be a patient that would be ideal for referral to see us, because we can do skin prick testing as an additional diagnostic modality. If the skin prick testing is negative, then we actually would recommend that they introduce the food into the diet. If the parent is not comfortable doing that at home, then we offer for it to be done in our clinic. But low positive immunocap results in the absence of prior exposure oftentimes could benefit from some additional evaluation by an allergist.
And my second question, I think one of your slides said that once the levels start going down, the risk of having true anaphylaxis goes higher. Is that correct? Or?
Not necessarily. So there's a lack of correlation between the height of the specific IgE value and the reaction severity. And so in general, the higher the levels are, the more likely you are to have a reaction, but the severity of that reaction does not necessarily correlate with how high the number is.
Okay, thank you.
Mhm.
Hi. Can you comment on the form that you showed from the Food Allergy Network in terms of when to check all the boxes?
Sure.
And how do you know that? Because I have a little guy with asthma, and he had a witnessed peanut reaction, and an egg allergy, and a shellfish allergy, and so I guess I could argue I could check epi on every box there, but...
So usually not, and FAN, the Food Allergy and Anaphylaxis Network, has actually inserted some symbols next to throat, lung, heart, and if the reaction is progressing. So those are usually the ones that we designate should be treated with epinephrine. If there's any throat symptoms, if there's any respiratory symptoms, if there's any cardiac symptoms, then definitely give epi right away. Or if the reaction is progressing to involve more than one organ system, then definitely give epi. But if it's localized symptoms to the mouth, skin, gut, then it wouldn't necessarily require epinephrine.
And what age can asymptomatic kids begin peanut butter?
Good question. So I'll say the verdict is out on that one. And, we used to think that delayed introduction of peanut butter had a role in prevention of food allergy, and we now actually don't think that. And there's a study that's going on right now in the UK called the LEAP study by Gideon Lack and their group. And it's a randomized trial where the intervention group is getting early introduction of peanut during infancy, and then they're going to follow them longitudinally to see whether the rates of development of peanut allergy actually differ. I think that'll be one of the definitive studies so that we could make a recommendation. At this point, I usually tell families that if there's no history of food allergy, go ahead and introduce it whenever you want to. If there is a history of food allergy, then I tell them to introduce it no sooner than 1 year of age.
On one of the slides, you showed that you use Chinese traditional medicine. What do you use and how effective it is for allergies?
Right, so we actually don't use Chinese herbal medicine, but it's traditional Chinese medicine is being investigated by the group up in New York at Mount Sinai. And there's a particular combination of 8 Chinese herbs that have been identified that may be helpful at decreasing the likelihood of persistence of food allergy. And so there's a trial that's beginning right now up at Mount Sinai to study that further. At this point, there's no other studies that have been done to evaluate Chinese herbal medicine or traditional Chinese medicine and food allergy.
Okay. Any preferences in between Alimentum and Ultravigen?
Alimentum, I think, is cheaper in most places, so I typically recommend that.
Okay. Okay, that's it.
And my question is kind of simple, but you mentioned that it takes 2 organ systems to diagnose anaphylaxis. Is mucocutaneous signs and derm considered one system, like if it was just lip swelling and hives?
So that's
like significant lip swelling?
It's considered one system.
Okay, but if it were the throat, same thing?
No.
It's different.
So that would be different.
Right.
And if
that's what I meant to say, the tongue, not the throat.
So if they have any tongue or throat symptoms, then I usually recommend that they treat quickly with epinephrine. I guess one thing that I emphasize to parents is that there's no downside to giving epinephrine. It's, in fact, a very well-tolerated medication. And even if epinephrine is given, if it hadn't really been needed, that's okay, because at least the child stayed safe. So I always tell parents, if you're kind of hedging and you're like, oh, is this anaphylaxis, is it not, go ahead and give it, and then bring the child to the ER.
Wheezing as well?
Wheezing actually is an indication for epinephrine in and of itself. And the important thing with that is that it should not be treated with albuterol or a bronchodilator prior to treatment with epinephrine, because those are classically the cases that can progress to fatality. Is that
so you treat with epinephrine first?
Yes, treat with epi first and then albuterol.
You mentioned before that to diagnose peanut allergy, you need consistency. If you have one reaction, what do you tell a parent?
So if we've had one reaction and that one reaction is fairly convincing based on the amount that was ingested, the form, the time course to the reaction, and the testing is supportive, then we diagnose them as having a peanut allergy and we tell them to avoid.
If it's questionable?
Then we look at the testing for some guidance. If it's questionable even after the testing, then that's a situation where it might be helpful to do an oral food challenge in our clinic and actually give them peanut and see what happens.
So you would do testing on every child that comes in that may have had a peanut allergy, symptoms of allergy, a peanut allergy, to confirm?
Yes.
Okay. A second question about allowing peanut butter. That goes for before the year, after a year, but not before. That goes for tree nuts as well?
Yes.
Okay.
I have a large number of families who are immigrants, and they tend to laugh at our order in terms of delaying food introduction and sort of give everything very early on. And just anecdotally, it seems like their allergy rates are a lot lower. And I'm just wondering whether a lot of this allergy is misdiagnosed as intolerance, and that they're actually just feeding these foods and tolerizing their own children, and whether people have looked at immigrant families and what their true rates of allergy are.
Yeah, no, it's a great question. And one of the theories is that the delayed oral introduction of food is in fact what's contributing to the rise in food allergy that we're seeing. And the reason that has been looked at is in part due to the fact that the rate of food allergy is quite low in the third world, but it is not low after those families migrate to the U.S. and adopt a Western lifestyle, including diet. So I have a number of children of immigrant families who have horrible atopic dermatitis, horrible food allergy, and when you ask them how they fed, they change their feeding practice from what the elders would have had them do. No one has really looked at the migrant families specifically to identify whether their feeding practices are protective or not, but I certainly am much less restrictive than I used to be in terms of delayed introduction of oral foods.
And one quick question. You had this slide of the IgE-mediated milk allergy, and you showed a difference between age 10 to 18 with the allergy possibly resolving itself. Does that have anything to do with what you talked about, the adolescent sort of risk-taking and maybe taking in more milk and possibly tolerizing themselves?
Potentially, but more so what that's likely reflective of is the fact that their immune system desensitized to the allergen on its own. And so what we know is that oral immunotherapy is an active way of desensitizing the immune system, but there are children who, even without exposure to a food allergen, their immune system will desensitize itself on its own. It just simply seems like it takes a long time, but if we give them a therapy actively, it might decrease that period of time that it takes their own immune system to outgrow it.
Hi, I'm sorry, I know you already addressed this, but the Food Allergy Network form, I have lots of trouble filling that out, because if you go and look at it, for instance, abdominal complaints, wouldn't that be a symptom of a systemic reaction, vomiting, for instance? So I feel like I need to put epi for that. Or for the mouth, you don't necessarily want them to get epi for itching or tingling, but if there's swelling of the tongue, I would think you want to do epi. So I end up writing little cryptic notes everywhere, and then decide maybe I should have just checked epi for everything. Any comments? Is there any other new form coming out, or is this what this is what we have?
For our clinic, actually, we've devised our own form, and it addresses some of the confusion that I think that you've brought up. For GI symptoms, if the vomiting is persistent, and it's not just one episode of vomiting and then they're fine, but it's persistent vomiting such that they couldn't keep an oral antihistamine down, then they should be treated with epinephrine. And I usually say that just makes common sense to parents, because if they try to give the Benadryl and they keep throwing it up, then you should give the epi.
This is for the school, so we've got to be pretty, precise.
Yep. And usually, most school jurisdictions are moving to a policy, such as in Northern Virginia, Fairfax County now treats every reaction, no matter how mild it might be, with epinephrine.
Actually, I was going to comment on that, because I actually have a child with food allergies, and this was my introduction to Fairfax County, despite being a provider there for a while.
Yeah.
And they will give the EpiPen. I had a patient the other day who got an EpiPen because he ate a fruit snack that on the bag it said manufactured in a plant that processes peanuts.
Yeah.
But on the other hand, if my daughter has a reaction and nobody says she ate a peanut, there's going to be a delay in giving her an EpiPen.
Right.
And I'm not sure how. I feel like at some point I need to address that with
it's a big problem.
County, but
it's a huge problem, and we're actually involved with some advocacy efforts on the national level to try to make it more uniform the way that school jurisdictions all across the country react to food allergic reactions. I think that the form is helpful only to a certain point, and so there are always going to be problems with any form that we could give a school, and there's a certain amount of judgment or discretion that provider, the school nurse, or others will have to use. And I usually always, again, err on the side of giving it. If there's any uncertainty as to whether it should be given or not, I recommend that they tell the school to give it.
Can we use your form, or is that copyrighted?
Our form, you can use it. So it's not on our website yet, but it will be. Mm-hmm.
What's the minimum age where you can do skin testing and blood testing, and what's the percentage of false positives for each?
Mm-hmm. So to address the first question, there really is no minimum age. If there's a history that we think is suggestive of a food allergy, we've even done skin testing in early infancy. The sensitivity of it is quite poor in early infancy, so you often end up with a lot of false negatives. The same is true of specific IgE testing in the serum. No one has really looked at the rates of false positives across the board because it turns out that it differs from food to food. But in general, we think that the specificity is somewhere around 80 to 90%, meaning that you might end up with anywhere between 10 to 20% false positive.
And another question for Dr. Wolf. The kids who have a texture aversion, the number is kind of growing. Many kids have resistance to eating solid foods. Would you empirically try PPIs for them and see?
I do, yeah. It's such a benign treatment that I do, and typically, the diagnostic criteria say you should try high dose, acid therapy for 6 weeks. A lot of times, frankly, we don't make it that long because of the family's anxiety about it. But yeah, I try for at least 3 weeks, 3 weeks of PPI therapy because it's so well tolerated and safe. Yeah, and also if they're having feeding issues, consider a swallow evaluation also, like a modified barium swallow or evaluation at a feeding clinic to have an OT or speech therapist evaluate the child.
I have a question about the dosing of EpiPen for the little guys, and also a question about prenatal recommendations for exposure.
So the dosing of the EpiPen that we use in our clinic is 20 kilos and above. We go to the EpiPen adult, which is 0.3 milligrams. Below 20 kilos, we do the EpiPen junior. That's a little bit different than what you'll see used elsewhere because there can be an underdosing between 20 and 30 kilos if you use the EpiPen junior up until that point. And so usually 20 kilos and below EpiPen junior, above 20 kilos EpiPen adult.
What if they're infants?
Infants, EpiPen junior.
Even if they're 5 kilos?
Mm-hmm. Yep. And then the second question about prenatal exposure to food allergens, it's a great one. It mirrors kind of what we had discussed before about the age of introduction of solid foods. No one really knows. And so if there's no family history of food allergy, then I usually let pregnant moms go ahead and eat an unrestricted diet. If there is a family history of food allergy, I have a discussion with them as to the potential avoidance of peanut and tree nuts. And some families will choose to avoid the known food allergens for their other child or children. It can get quite restrictive, and so I think you always have to weigh the pros and the cons of all of this, especially given the fact that there's no proven evidence that avoidance of these foods during pregnancy is going to help in any way.
Could you comment on the efficacy of the sublingual immunotherapy for the treatment of allergies?
So it's sublingual immunotherapy for food allergy has not been looked at as extensively as oral immunotherapy, and oral has been looked at for milk, egg, and peanut. The results actually range in efficacy between 70 to 90%, meaning that 70 to 90% of children who participate in these trials in the intervention group will have an increased tolerance of food allergen over the course of the treatment. It doesn't necessarily mean that 90% of them will completely lose their food allergy, just that they'll be able to tolerate significantly more of the food than they previously were able to. For sublingual immunotherapy, the only trials that have been done so far are for tree nuts, as well as there's a trial underway for peanut sublingual immunotherapy right now, but all the rest of them have been oral.
Is there great evidence that maternal diet with mothers who are breastfeeding, that the food does affect allergy in the babies?
Unfortunately, there's not. So there's a wealth of evidence, but the evidence is conflicted, and it's about just as much evidence in either direction. So there's some data that suggests that the maternal diet is a risk for the subsequent development of food allergy. Other evidence suggests it's preventive. And so we really don't know what the best thing is to do. I can tell you, for my wife, when she was pregnant, I told her as an allergist that there was nothing that she needed to avoid. And she ate peanuts and tree nuts all throughout the pregnancy. But other families will choose, like I said, based on the history of food allergy with their other children, to avoid, milk if they have another child with a milk allergy.
Because that
or whatever
is
it might be.
difficult for mothers. I mean, that's a hardship for them to do.
Particularly during pregnancy, and so their nutrition is what comes first.
Yes.
Hi, this is a question for Dr. Wolf. I was just wondering if there's a particular food that's most often implicated in EE, or do you find that most of these kids have to be on off of all 6 of those foods?
So I'll probably defer a little bit to Dr. Sharma. I don't know. Frankly, once the EE is diagnosed, we work very closely to help answer that question and identify exactly what the food is. So I don't know if you have any.
I can comment briefly. Yeah. So again, the answer here is that we just don't have enough evidence to say. The group up at CHOP has looked at their 13 to 14-year experience with EE, and they've listed what they consider the top 10 most prevalent foods implicated in EE. Milk is number 1, and so we always look at cow's milk very closely in any patient that's been diagnosed with EE. Following milk comes egg, then soy, then peanut, and then the list continues beyond that. But again, we work very closely, and so I think one of the nice things about the food allergy program is that we have this collaborative effort both between allergy and GI. So for gastrointestinal food allergy, they'll usually see Dr. Wolf or one of her colleagues first, and then subsequently get referred to see allergy.
I will mention, just to round out, for babies who are, let's say, having excessive vomiting, maybe loose stools, who we suspect some sort of food protein allergy or sensitivity, I will tell moms to start with milk and soy. Milk being the more common thing, but there's about a 30% cross-reactivity between milk and soy. So I automatically say milk and soy, and then kind of work my way down that list that Dr. Sharma mentioned. But in the older kids, typically, we then once we diagnose EE, we have them do the formal testing and go from there.